it's a hot topic today for you ladies. HRT, which stands for Hormone Replacement Therapy, is what everyone seems to be weighing in on these days. If you are in premenopause, menopause, or postmenopause, you are probably very familiar with this term. Something that my OB said to me a while ago has just resonated so much with me, and that is that women are now living a third of their lives past menopause. So why are we not focusing on what we can do to feel our best rather than just push through? My guest today is nurse practitioner Lisa Grissim from Restore Hormonal Vitality and Wellness Center here in Nashville, Tennessee. We are talking all things hormones, what they are, when and why they suffer, what are the symptoms, your different HRT options, and how it can help. If you are someone who is just not feeling like yourself anymore, if you feel like someone turned the dimmer switch on your mood all the way down, or your libido is just not what it used to be, this might be something you're going to want to hear. This is not medical advice, it's just a conversation, so please ask your own doctor or wellness center what will work best for you. Without further ado, let's get to it. Here's my conversation all about hormones with Lisa Grissim. All right. Well, welcome to the podcast. I have I would call you my hormone specialist always. I don't know if you would call yourself that. Lisa Grissim here with me today. And you have been one of the most requested topics to have on the podcast. Okay. So today we're going to talk about hormones, hormone replacement therapy, women's health, all of the good stuff that goes along with aging, perimenopause, menopause. What's after menopause?
Postmenopause.
Postmenopause. Okay. We're going to talk about all of that and what we can do to feel better. So I'm going to ask you, I will tell everybody that you are a nurse practitioner.
I am.
And can you just give us a little bit of your background of how you got into doing what you're doing today?
So I've always been in women's health. Graduated Vanderbilt Nursing School in 1987. My gosh, that's so long ago.
But that's why you get to do what you do today, because you did graduate a long time ago.
Yes, and did labor and delivery for probably 15 years. Just all aspects of women's health. And then in 2008, I got really interested in aesthetics, and I opened up a medical spa. It's called Profiles Laser and Medical Aesthetics. And my goal there was to provide a place, a center for age management. For men too, but, really women.
Yeah. On the outside.
Yes, on the outside. So we did lots of Botox, lots of dermal fillers. We still are, a full laser center.
Yeah.
And I just realized that we didn't have the complete picture for age management because you can throw thousands of dollars at what's happening on the outside.
Yeah.
But if you don't address what's going on the inside, you're really missing, to me, the biggest piece of the puzzle. So that's when I went back to school to become an NP, knowing the entire time that all I wanted to do was hormone replacement therapy. And so that was my impetus.
Were you feeling like when you were aware that we were not matching our outsides with our insides, were you like at the time going through that, or were you hearing other women say it?
No, I was going through it.
Yeah. So you were aware.
Oh, absolutely.
Were people talking a lot about hormones back then and hormone replacement therapy?
They were.
Okay.
Yep. When I was in my family nurse practitioner program, I felt like every woman coming through Profiles was going to a certain center in town.
Okay.
And they did a ton of pellet therapy. And so I had a little hormone radar.
Okay.
If anybody talked about hormones, my little radar went up.
Right. We were just saying, when I came to first see you, we spent what I really was, well, first of all, shocked by and then appreciative of is you and I spent probably an hour plus just sitting in your office, not even like a medical room, just talking. Really not so much about my results that I already had done, but just talking about how I was feeling. You answered all my questions, and I just thought, this is the most thorough, doctor's appointment I have ever had.
Thank you.
And you and I were just saying, I would love to treat this episode as like someone's first initial consultation, because I think there's so much information.
There's so much.
And there's so many questions and a lot of different opinions from a lot of people who have big degrees behind their name. And so you think, well, this doctor said this, so they must be right, or vice versa. Walk us through when somebody comes to see you, or not somebody comes to see you, when someone calls your office to make an appointment, what are the kind of steps that they go through before they even come to you?
Okay. Well, it's just more time efficient for the patient and for me we will send them a lab requisition.
Yeah.
And we draw labs. We send a new patient intake form, and it feels like a book that they've got to fill out their patient history. And then when we get the labs back, then we sit down and
Are the labs always the same for everybody?
Initially, basically, unless
so
there's a special request.
What's usually on the labs?
Well, we just do a CBC, a complete metabolic panel. I like to look at what's going on with insulin resistance, and so we do a hemoglobin A1C.
Okay, that's for like diabetes.
Mm-hmm.
Okay,
and then we look at all the hormones. We look at total and free testosterone. We look at progesterone. We look at estradiol levels.
Is that estrogen?
It is.
Okay.
Yes. And I also look at TSH, free T3, and T4, which all are markers we look at for thyroid function.
Okay.
We look at vitamin D, B12. Yeah.
What's the difference between free range? What did you say? Free range testosterone and testosterone?
Free and total testosterone. Okay. So total testosterone is it's the culmination of free testosterone. You can call it free and unfree, or bound up and unbound.
I'm thinking free range like chickens. I don't know where free range testosterone. Yeah. Okay.
So if we have testosterone in our bloodstream and it's bound up to a protein, then it's not available for the receptor sites. Okay. So really, free testosterone is actually more telling than total.
Okay.
But somehow in this space, we always focus on total.
Right. Okay. So we come to your office and you have our lab work.
I do.
And you've seen it. And what then kind of questions are you asking the person sitting across from you?
How can I help you? Where, how are you feeling?
Yeah, I think that actually is exactly what you said.
Yeah. And, that just starts the conversation. And then I learn about what specific symptoms and how that patient's feeling.
Yeah. Do you have are there the most common symptoms women are saying to you?
Oh, yeah. Women are fatigued, lack of motivation, gaining weight. Yeah. They can't sleep. They don't feel like themselves emotionally. It's women basically end up at a point in their life where they're saying the same thing to me if they, come. But of course they bring their own life story and their own vernacular with them. And so it's basically we end up in the same place complaining of the same things.
Yeah. And is that pretty much all from menopausal symptoms, perimenopause? Okay.
Yes. Like I can't tell you how many women say, I don't know what's wrong with me.
Yeah.
I have a great marriage. I don't have these stresses with money or my kids are good. Everybody's healthy, but I'm depressed. I lack joy.
Yeah. I think those were my exact words.
Yeah. And it's very common.
Do you feel like a therapist sometimes? Because I think too, you probably evoke a lot of emotion in women when you say, how do you feel? How can I help you? Because they probably are not used to hearing that from their provider.
You're right. And so we have Kleenex available.
I did not cry. And I know so many people kept asking me, well, what was it you were feeling? What were your symptoms? Because I think there's a lot of different symptoms. You don't have to have all of them, right?
Right.
And I am not someone who I'll just say, I am not in menopause. And I think you said my estrogen numbers showed I was not either. But just because of my age, I'm not far off. So I think a lot of it kind of lined up. And I just, for lack of a better word, just felt like the dulled down version of myself and couldn't understand why. Because like you said, everything seemed to be totally fine and totally normal. And
Yeah,
I was,
why do I feel this way?
I was exhausted when I woke up in the morning. I felt like I was gaining weight. I felt like none of my clothes fit me. I felt bloated. I just felt blah, for lack of a better medical word. That could just be, blah. Just encompasses blah. Encompasses everything. Okay. So you've gone through how they're feeling, and then talk to me, because I know you love this topic, about looking at the ranges. If they fall in the normal range.
Okay. So what I do, and I did my training with Dr. Neil Rouzier through WorldLink Medical, and what he teaches is hormone optimization.
Okay.
And so I try to spend time with patients educating them that the reference ranges that we get back from the labs, when it comes to our hormones, at a certain point, those are just the mean, that reference range is the mean average of women around the age of the patient. That is what's normal.
Yeah.
Okay. So when it comes to, let's say, postmenopausal, it's normal to have no hormones. That does not mean that it's optimal.
Gotcha.
So normal does not equate to optimal.
I love that.
With certain hormone values. And so that's what I do, is I optimize all those values for patients.
Do you think that a lot of primary care doctors are focusing on the normal versus the optimal?
Absolutely.
Yeah.
It's all about the normal. And that's why during that initial consult, I just really want patients to understand your doctor is not going to understand what I'm doing because we're not taught this in school.
You're not.
You know, we're really taught it doesn't matter what the patient's telling me. I mean, if I'm going to do it from a traditional standpoint,
right.
I would be looking at the reference range and going, well, you're fine.
Yeah.
You're within the normal range.
Yeah.
You're fine. Sorry. Go deal with it.
Right. You're fine.
Yeah.
Yeah. And fine is just, it's meh, blah.
Yeah.
Yeah. Someone asked a question for the blood draw. She said, do hormones fluctuate throughout the day? And if so, is a single blood draw an accurate reading of what you're going through?
Hormones do fluctuate throughout the day. And a lab draw is a snapshot in time. I truly believe the trends are more telling. But there's certain things that we can look at that will let us know where that woman is on that path.
Is that why how you feel is more important?
Yes, absolutely.
Yeah.
It's honestly, to me, how the patient describes how she's feeling, even if we go ahead and work on hormone replacement therapy, it is equal, if not more important, than those ranges.
Yeah, okay. Can we go through kind of just a few of the hormones you test for, and I'm going to ask you to tell us the role they play, why they're important, why we need to not be depleted of them.
Okay.
Okay. Estrogen. It seems like it's the big dirty word of estrogen therapy. So I'm going to ask you what it's responsible for first.
Estrogen, I think of estrogen, and I hope this comes out right, but I think of it as all things juicy.
Okay.
Okay?
I mean, it's descriptive.
It is, but it is the suppleness in your skin.
Okay.
You know, when women are deficient, oftentimes they're dealing with vaginal dryness. Estrogen corrects that. It even down to the lining of our arteries. It makes the lining of our arteries juicy and supple.
Okay.
So I don't know if that's offensive, but that's
not offensive. I mean, it's descriptive.
Yes.
I mean, it makes sense.
And it's estrogen's also a mood stabilizer. It's so many good things.
Okay. So estrogen equals juicy.
Juicy.
Okay.
And it's also a tissue builder.
Oh.
So on a super, super basic level, I tell patients, think of estrogen as a tissue builder. And that happens in the lining of the uterus. It happens in the breast. It can happen anywhere that there's an estrogen receptor in the body. And if tissue builds and builds and builds, and there's no governor to it, then we're going to end up eventually calling that a growth or a tumor.
Okay.
So that there comes progesterone, because progesterone is the governor that makes sure the estrogen doesn't build up too much.
Okay. So they need to go hand in hand.
They do. They need to be in a healthy balance.
Okay. So would someone ever take estrogen and not take progesterone?
Yes. There's schools of thought on that.
Okay.
If a woman, older thinking is if a woman's had a hysterectomy and she doesn't have a uterus, that she doesn't need progesterone.
Okay.
Okay. That is highly held belief in the medical world.
Yeah.
But then you're ignoring the fact that the woman still has breast
Right.
and a brain.
Right.
Yeah.
Because what's the progesterone doing for us?
It is, I think of progesterone as anti-endometrial cancer, anti-breast cancer. It also helps women sleep if they take it orally.
Yeah, I found that highly, because I was saying that to you. I could fall asleep in a hot minute, but I was waking up consistently through the night, and then I was waking up in the morning just still feeling exhausted.
Yes.
Yeah.
And so progesterone, most women love their progesterone because they sleep so much better.
Right.
And it can be a mood stabilizer. Like in perimenopause, just adding progesterone can really help the fluctuating estrogen.
Okay. So is estrogen, when does it stop dropping? Does it not stop dropping till we're in perimenopause?
When does it stop dropping?
Sorry, when does it start dropping?
Well, perimenopause can last for a very long time.
Okay.
Okay. So, and they can drop over years.
But are we pretty much have a good amount of estrogen until we hit
perimenopause? When we hit perimenopause, what happens to estrogen is it makes no sense. It might be 400 one day. It might be 30 the next.
Okay.
It's just all over the place. And if you were to take a lab draw every single day, it would make no sense to the provider.
Okay.
So Dr. Rouzier teaches don't even do it if a woman's in perimenopause because it will drive the provider crazy trying to figure out what's going on.
Okay. So the estrogen for the juiciness, the progesterone for sleep and mood stabilizer, and to balance out the estrogen. The favorite of my new favorite thing, I feel like I talk about it as much as I talk about what I'm having for dinner, is testosterone. I have to actually tell you, I didn't even know women had testosterone. I thought that was just found in men. What is testosterone doing for us as women?
It's such good stuff. It is, well, from a scientific point of view, it is supporting lean muscle. It's supporting strong bones. It's energy. It's a sense of well-being.
Yeah.
Of course, it affects libido. I think most people always associate testosterone with libido. But it does so many more things.
And does it drop drastically in perimenopause, menopause?
It's the first hormone that we start to lose as women, and it happens very slowly. Okay. And so, what I find most women don't even realize, because we're women, we have families, we're pushing through. Yeah. You've still got to get up and get it all done. Yeah. So you just push through.
Yeah. And I remember you saying that to me in the first time I met you was, could you push through menopause? Sure, you could. You gave birth. Sure, you could. You could do it. But would you like to do it and feel good at the same time? Then, yeah.
I say, look, I'd like to think that I can help women go through perimenopause with the least amount of drama.
Tragedy.
Yeah, tragedy.
Divorce.
Yes, that
job
too.
Firing, friend alienation.
Oh yes, yeah. It's life altering. It truly is life altering.
Yeah. How do you know? I feel like there's a lot of talk about how do you know how much to dose someone for testosterone?
For testosterone, well, we look at height and weight. We look at. I like to look at where their FSH is, which is follicle stimulating hormone. And you have to have a starting point. Okay. You have a starting point. What I will do, I'll initiate HRT. I'll have the patient, depending what delivery method they've chosen.
Do you have a favorite delivery method, or is it just patient dependent?
Well, I feel like my role is not to impose my personal favorite on people. It's just to give them their options.
So the options are?
There's creams, there's capsules, there's pellets, there's rapid dissolve tablets, there's tinctures, there's serums. Mostly what I deal with is transdermal delivery methods, which that would encompass the pellets, and that would encompass creams. That would encompass a rapid dissolve tablet
So the pellets for lasts every 3 months
for women.
for women. What about for men? Do men can do the pellets too?
Men do pellets.
How long, it lasts longer for them?
Their pellets typically last 4 to 6 months.
Okay.
And I tell women around 3 months, but I do have some women that get their pellets at 8 weeks and some that go to 16 weeks. For men and women, what determines that is the energy demands that they put on their body.
Okay.
And so more energy expenditure, they're going to go through pellets more quickly.
Okay. And then the gel and the creams, those are like everyday,
They
topical.
are, and they're every day.
Okay. All right. Vitamin D. I didn't even realize that was such a big...
It is so important.
Yeah.
It is such a player in our immune function. Low levels are associated with depression, with weight gain. Vitamin D, it's extremely important. And it's almost epidemic that people are deficient in it. I'll have patients come in, that even work outside in the sun all the time, and they're still low.
Yeah.
I don't know what it is.
Yeah, I think you were surprised my vitamin D was fine, but a couple of years ago, someone told me this, and I think I just take like the highest over-the-counter
You're good.
vitamin D. And I think you were like, oh, your vitamin D is actually...
Yeah, it's unusual to see that, really.
Okay, another big question was, when is it optimal to start hormone replacement therapy? Is it...
Well, I would say that really depends on what the patient is experiencing.
Okay, symptom-wise.
Symptom-wise. I mean, I have young patients that are in their 30s that are doing what's appropriate for hormone replacement therapy.
Okay.
So, probably testosterone.
This might be a dumb question, would you ever do HRT on someone who still wanted to have a child?
I do.
Okay.
Okay. But I tell them, if you're planning on getting pregnant, we need to stop testosterone.
Okay. Because?
There's just no studies.
Okay.
Nothing to support it. It's kind of covering CYA.
Okay. If you, though, are like, okay, I'm in menopause because I've, stopped getting my period or my counts are low, but I have no symptoms, are there still benefits to doing
absolutely.
HRT? Like what?
So most of the time women are coming because they are experiencing symptoms. Hot flashes, night sweats, vaginal dryness, mood instability, weight gain, heart palpitations, anxiety, just feelings of gloom and depression. That's what drives them to seek help.
Right.
Okay, but behind the scenes, what most people don't understand is that our hormones have an innate protective mechanism that help our bodies fight against all the diseases that we associate with old age.
Okay.
And so, even that woman that is, if she's postmenopausal and she's not experiencing those, because you will meet people that don't.
Yeah, they say it was fine for me.
Yeah.
Yeah, never felt a thing.
Yeah, but the Wi-Fi in their body is not working like it used to.
They could feel better.
Oh, absolutely. They could feel better, but they also, why wouldn't you want to replace those innate mechanisms that help protect you against Alzheimer's and dementia, macular degeneration, osteoporosis, atherosclerosis?
Because there's been a lot of studies done, correct, that are showing now that hormone replacement is fighting these long-term diseases?
Absolutely. And I know I've shared with you, Jen, but I was so excited. There was a study that came out in June of 2022 in the Cancer Journal, which is a very reputable journal. And the title of it is Hormone Replacement Therapy and Reduction in All-Cause Mortality and Cardiovascular Events. So it's basically saying, hormone replacement therapy reduces all-cause mortality. That's death from any disease source.
Why do you think, that comes out in the Cancer Journal, and yet it's still not something that the traditional medicine is pushing, insurance covering, being talked about? Do you have thoughts onto why that?
Oh, yeah.
Is it a whole other episode?
It is. It is a whole episode. Everything, that's one thing I always ask patients when they come in, are you scared of hormones? Because a lot of people are scared of hormones. Yeah. And that all stems back to a huge landmark study called the Women's Health Initiative. You'll see that referred to as WHI. That was a study that was abruptly stopped in 2002. So now we're looking at a 21-year-old study. The medical media picked up premises from that, and it was everywhere. And women across the world quit taking their hormones because they were scared to death that it was reported that was going to cause a 26% increase in breast cancer. Yeah. And if that was accurate, that would be terrifying.
Yes.
What was reported, because, fear sells, is the relative risk and not the absolute risk. And that's a big difference.
In what way?
So if there's 4 of us in the room and we want to do our own little study about who likes strawberries, and let's say one person doesn't and 3 people do, well, then we could say relatively one third of the women in our study does not like strawberries. Okay. So do you get that?
Yeah. Yeah.
That's a very, very plain example.
Yeah. No, I like plain. That's good.
Yeah. But,
and was there something about the age, what were you saying about the age that they were starting it at and what they were being given?
Okay, so the Women's Health Initiative is a very important landmark study because
this is the one that made everybody scared and have people saying to me, have you done your research? Hormones cause cancer, which is a big statement.
It is.
And I think it's all come from this one study. And before you even say it, I will preface to people that I also spoke with my OBGYN about this, and she said the exact same thing that you're about to say. So before someone says, well, an OB wouldn't think that, my OB also said the exact same thing that you're about to say.
Okay. I hope I say the right thing.
You're like, wait, what am I saying?
What am I supposed to say?
What we were talking about with the age that they were given it, and then the you were saying the fancy name.
So with the Women's Health Initiative, it was huge. I think there were about 17,000 women in the study. It was a very expensive study to conduct. The hormones that they used in that study were synthetic hormones. The estrogen that they used was something called Premarin, which is made from pregnant horse urine. I know.
That seemed like a good idea at the time.
So that's Premarin. And then they used a synthetic progestin, which was the answer for our natural progesterone. And that was called medroxyprogesterone acetate. So you'll see that in the literature referred to as MPA. It's really interesting in that study when you really break it down. There were different arms of it. Somehow estrogen really got demonized. That if you look at it, it's the arm of the study when women were only taking the estrogen. We didn't see an increase in breast cancer.
Okay.
We saw the increase, and it was slight. But we saw the increase when they combined the estrogen and the medroxyprogesterone. So there's some people who really think that the culprit was the medroxyprogesterone.
Okay. All right. And that's where it got the dirty word from.
Yes.
Basically.
It did.
Yeah.
And so, we have, in the medical world, we have medical societies that give us protocols on for standards of care and how to treat patients. So ACOG and NAMS, those are 2 in women's health that are very big. From the Women's Health Initiative, what they say, their position statement on it is give women the lowest dose possible for the shortest amount of time to correct the symptoms.
Yes.
But what they're referring to is synthetic hormones. Okay.
So versus what are the other kind of hormones?
More natural. We call them bioidentical.
Bioidentical hormones. Okay.
And we call them bioidentical because they are identical on a molecular level that what our bodies make.
Okay. So is the hormones you're providing, say, or someone like you is providing, is that different than if you were to get a prescription hormone? Is that the more synthetic hormone you're getting? from your doctor?
Well, it depends.
Okay.
It depends. You can get bioidentical hormones that are commercially made.
Yeah.
That's estradiol, and that is progesterone.
Okay.
Okay. I do not prescribe Premarin. I can't imagine why anyone would anymore.
All right.
And I would not prescribe a progestin, like medroxyprogesterone acetate. We call that Provera.
Okay.
When we used to prescribe those, or when they were prescribed together routinely, we called it Prem-Pro.
Okay. So you were saying that the kind of one school of thought is the lowest dose possible for the shortest amount of time, which was also another big question. And I was saying to you earlier, there's one school of thought of just get them through the symptoms. And then there's another school of thought of I'll be on testosterone till the day I die because it makes me feel so good. You're on the school of thought of
why would I ever want to not feel good?
Right.
Because
so I guess the question would be if hormones get us through the whatever, let's just say 10 years of menopausal symptoms, and then we go off of them, how will we feel? Are we feeling, what version of ourself are we even getting? The postmenopausal, but not on hormones version. What does that feel like?
That would feel like what the woman felt like when she came in initially.
Okay.
And then also you're not taking into consideration when you quit taking them.
Yeah.
You're taking away those protective benefits that protect our bones, our brains, our hearts. Actually helps reduce our risk of breast cancer, helps reduce our risk of colon cancer.
Okay. So now at this point, when the symptoms are gone, you're staying on it for health reasons, mental health reasons. Too.
Yes, absolutely. My dad's 85, my mom's 83. I can't imagine looking at either one of them and saying, sorry, it's time.
Okay.
So really those statements really apply to the synthetic hormones.
To the synthetic. Okay. So if you're taking the bioidentical hormones, you would keep someone on it as long as they wanted, forever.
Definitely. Now, we need to go back a little bit, Jen, and talk a little bit more about the Women's Health Initiative.
Yeah.
Because I think you raised the question about timing.
Yeah.
So on average, women go through menopause, on average, like 51 or 52 years old. So the Women's Health Initiative, one of the criteria for these 17,000 women to be in the study is that they had to have gone through menopause at least 10 years prior, and they could never have taken hormones.
Why would that have been the prerequisite?
I do not understand that, but that is how they set the study up. So when you understand that hormones are protective, then think about they've taken a population of women that have not had innate protective benefits for 10 years. So the roots of all these diseases that we associate with old age could start to take effect. Does that make sense?
Yeah.
So you'll hear that timing is important. And it's really coming from that.
Okay.
And it is important. The closer you start taking hormones to when you've gone through menopause, just the better outcomes you're going to have with longevity and reduced risk and everything.
Okay. But is it harmful to your body to start them at a later age if you've never taken them?
Well, there are contraindications in certain delivery methods. Okay. So if I have a patient who's 20 years post-menopause and she wants to start, I'm going to be looking at other what we call comorbidities. Is this patient obese? Does this patient smoke? What's going on with her lipid profile? Because there are certain delivery methods of estradiol that if it gets metabolized through the liver, it's going to come into contact with an enzyme called something proteinase.
Okay.
It's a very, very long word. And it can increase the risk of plaque rupture. So, and I'm looking at that. We're looking at history of blood clotting.
But if you've been on it the whole time, then the risks aren't the same.
Correct.
Okay.
And even for those women that are decades past postmenopause that start on hormone replacement therapy, if they're going to have an event, it's usually going to be within the first year.
Like a reaction to it.
Mm-hmm.
Okay. Yeah. Because I do think there's probably a lot of women who will be listening who are past that perimenopause and menopause stage, who never knew this was even an option when they went through it.
Right.
And might find themselves thinking, well, if I'd known,
I would have done it.
I would have done it. So I guess, yeah, it's like, is it too late?
And they feel like it's too late.
Yeah.
No.
Okay. I love that. Talk to me a little bit about the direct correlation between libido and, well, either libido and menopause or libido and lack of, is it one specific hormone? Is it just testosterone?
It's testosterone.
Okay.
It really is.
Do you have that complaint a lot of women coming in?
Absolutely.
Okay.
I truly believe bioidentical hormone replacement therapy saves marriages. We've already talked about how the woman feels.
Yeah.
And she's gaining weight. She doesn't have a good sense of her body image. Plus the idea of sexual, a lot of women end up just losing all sexual impulse.
Wow.
And then when they do have sex, it can be so painful.
Yeah.
And that can lead to all kinds of relationship issues.
Yes. Is the pain part fixed with testosterone, or you need the estrogen for that too?
It can help.
Okay.
It can help. If I have a breast cancer survivor, testosterone can definitely help with that. But estrogen, we go to estrogen.
Okay. If someone is a breast cancer survivor, is the hormone treatment different after? Or?
Well, now we're getting into some territory.
Okay.
We might need to save that for another discussion. Okay. I do have women that arrive in my office begging for hormones because of their quality of life.
Yeah.
And those women are usually saying to me, my quality of life while I'm here is more important to me than embracing this fear of a reoccurrence.
Okay.
So, yeah, that's a tough one.
Yeah.
It's a tough one because of the litigious environment that we live in the medical world.
Right. Gotcha. Okay. Not negative side effects, but side effects of testosterone if you have too much, if your dose is too high.
Of testosterone? So that's a common thing. And I tell all my patients, if you feel that you're road ragey or you're snippy, you're just overreacting to situations that later you go, why did I react like that? That is a really good indication we've got too much testosterone on board. A healthy libido is a healthy thing.
Yeah.
Nymphomaniac is not the goal.
I told you someone I knew went on it and she said, oh, I just didn't have time for all that. I needed to go off of it. I was like, oh man.
And that's probably just too high of a dose.
Too high of a dose, yeah.
And I know you had some questions of what's the right dose for different testosterone. That's so super individual. And that's really a conversation with the individual patient.
Okay. And does that really go back to like, what are your symptoms? Like, are you feeling good? Are you feeling too much of, like you said, the road rage or?
So my goal with testosterone for women is to find the dosing and the method that gives them the positive benefits without the negative.
Yeah.
And there are negatives.
Yeah.
Testosterone can definitely stimulate hair growth where you don't want it.
Yes, you said that to me. I think I was like, and you said, or the deepening of the voice. So
and that can happen.
Don't think I wasn't talking every day and like listening to myself. It's like, okay, I think I still sound fine.
And that's usually the deepening of the voice in my clinical experience is really dose related. In some people, the testosterone can convert to DHT on the scalp and cause hair thinning.
Okay, that was a big question. People kept saying to me, aren't you worried about going bald? And I was like, oh my gosh, I'm not, but should I be?
Well.
Too much.
Too much.
Too much.
I've had too much testosterone on board myself.
Okay.
And I felt very aggressive. All I could think about was sex.
Right.
My hair was thinning. My skin was oily. I was breaking out.
Okay.
These are unwanted side effects.
Right.
Yes.
If you get a pellet in, which will last for 3 months, if it's too much, can you get it out or you're stuck with that till it is dissolved?
You could go in there and dig around, but that would not be pretty.
Yeah.
And so the goal is to not overtreat.
Okay. Start moderately.
Start
Yeah.
even moderate or a little bit. You can always add.
Right.
You can't take away.
Do primary care doctors do like the pellet therapy?
There's probably some.
Okay, but it's not a common.
Not at all.
It would be like a more prescription type.
Well, it's a specialized training.
Okay.
Yeah.
Do you think women have just always, for so much, like I think about like my mom's generation and my grandmother's generation, and think about when they were going through menopause and all these symptoms that now I feel like we talk about all the time. I don't know if they maybe talked about it with their best friend. I never heard my mom talk about it. I kind of thought menopause meant you stopped getting your period and
That was it.
maybe you had some hot flashes. You would hear the term, I'm getting hot flashes. And that was it.
Right.
And then you were just done. Did they just ignore, did they just kind of push through, like you said?
Well, I think there were probably women that were put into mental facilities during that time. Mm-hmm. We just have such a greater understanding now. And I do think that our generation, we're just not going to lay down and put up with it.
Right.
I mean, we now live, years ago, our life expectancy was much shorter.
Yeah.
And now we're living a third of our lives in a postmenopausal state. I want that third of my life to have, I want to have energy and motivation and vigor.
Yeah.
I want a libido.
Yeah. It's like we're done raising our kids now.
Let's have some fun.
Yes, let's have some fun and have energy too if you're going to be a grandma. I mean.
Right, absolutely. And you want healthy bones and you want muscles.
Yeah.
You want mood stability.
Would you ever put someone just on one, or you kind of believe they all go hand in hand? Like, will we all have, at some point, would I go through menopause and basically have a depletion of every single hormone that we talked about? Okay.
Absolutely.
Okay.
And so that's just really individual with the patient. The way I see it is it's that woman's menopause journey, and I'm just there to facilitate.
Okay.
And to help her with, I just feel like my job is to give them as much education and information and their options, and then we just go from there.
Okay. I'm going to ask you, this was another big question. Yes, weight gain, but more so people refer to it as bloat. They feel bloated, whatever that means, and abdomen weight gain.
Yes.
I think that's called, what is that? Visceral fat.
Yes. And, the average woman will gain, I think I'm quoting this correctly, like 9 to 12 or 13 pounds.
Okay. In menopause?
In menopause without changing anything.
Okay.
And so it,
Why is that? Just your metabolism slowing?
Everything's slowing.
Okay.
I mean, our bodies are a machine. And if you think of them as a car, and an older car, things are not working as well.
Right.
They get creaky. Yes.
So is testosterone revving up your metabolism? Or is it doing one thing in particular to either make you lose weight or not gain weight?
Okay, testosterone will help reduce insulin resistance, which is a major driver in weight gain.
Okay.
Testosterone will help a person maintain and gain lean muscle.
Okay.
Okay, so that's all a part of it.
Yeah.
Testosterone, it might take 9 to 12 months, but if a woman starts on testosterone, she is going to have a different body composition in about 9 to 12 months.
I'm excited for the next, what have I got left? 7 to 9 months.
Yes.
It'll be a whole new podcast to see what my testosterone body looks like. What is the visceral, I feel like you do hear that. When you said that, I was like, yes, that's what I keep hearing. What is, it's just belly fat?
Hormonal weight gain is in your belly.
Okay.
Visceral fat is that brown fat that is around your organs.
Okay.
It's actually the most dangerous fat.
Like for heart attacks and stuff?
Yes.
Okay.
Yes. And so a lot of people want to do BHRT. I encounter this all the time because their friend went on it and they saw they feel good and they've lost weight.
What is BRHT?
Bioidentical hormone replacement therapy. And I always make that really clear. This is not magic for weight loss, but what I see happening, Whereas a woman who's been suffering with all those symptoms, it becomes this terrible downward spiral. You're tired. You don't feel good.
Yeah.
You have no energy.
Yeah.
You're grabbing simple carbs to get energy, but you don't have the motivation to get off the couch. And it's just a spiral down.
Yeah.
But when we get their hormones optimized, what I see is that they feel better and they're motivated. And when you wake up in the morning and have energy, you can approach every decision differently.
Yes.
And so I do see weight loss, but I don't ever want any of my patients to think this
Take
is magic.
it for weight loss. Yeah. Well, and that is the one thing I would say with the progesterone is I felt like, and I remember you did say to me, you said, if you're taking too much, you'll feel groggy. But I was just waking up in the morning and just getting out of bed with an energy of just rest, really. And not a fake energy, not like you don't feel like you drank a Red Bull or you took a weird medicine or you drank too much. It's like a youthful energy.
You're rested. It's a whole different feeling.
I felt that really quick because the testosterone takes, that was
Takes
another
a little
question. Yeah, 3-4 weeks-ish.
Yes.
Kind of like a sneaky. Because the first week I kept thinking, I don't feel anything. I feel the same. And then all of a sudden one day I was like,
And that's what I tell people. It's not like it's going to hit you all at once. You're just going to have the thought, gee, I feel good.
Right.
Yeah, it's kind of a sense of well-being.
Yeah.
That's the biggest feedback I get from people.
Yeah. I saw someone, the lady we were just talking about on Instagram, and she posted this funny video the other day. She talks a lot about menopause with her husband, and it was like a tongue-in-cheek how the FDA has just approved a over-the-counter gel for male erectile dysfunctions. And it was basically in the irony of course they did, right?
Of course they did.
Why can't women have any over-the-counter hormone things, whatever? And she was making the joke. She's like, well, I'm glad you all have these erectile penises. Too bad you won't have anywhere to put them because none of us can get our stuff over the counter. We all have to go through like insurance. And her husband was like, oh yeah, I'm definitely for the over-the-counter medicine for women. But why do you think, I don't know if you have a thought on it, but a lot of people were writing in saying insurance doesn't cover it. I can't afford to do this.
It doesn't. And that's kind of, it's just a hard place because if a provider was trying to do this and get insurance coverage, then you're having to follow the guidelines of NAMS and ACOG.
What's that?
Those are the societies that give us protocols.
Okay.
Do you remember when I was telling you their statement on hormones is the lowest dose possible?
Yes.
For the shortest amount of time, just for symptoms.
Okay.
Yeah, they're not going to cover bioidentical hormones.
They won't cover bioidentical.
They won't.
And that's the difference. They cover the synthetic.
They would.
Yeah.
But then you're going to have to prescribe them according to those. And who would, I don't know why anyone would be prescribing synthetic hormones in this day and age. I really don't. You can get bioidenticals that are commercially made. So there's different ways to get them, okay? I deal with a lot of compounding pharmacies, and they compound according to the individual patient needs. But you can get estradiol and progesterone that you would get from Walgreens or CVS.
You can.
You can. They're commercially made.
But how do you know you're putting the right amount?
You would need to be working with a provider.
Okay, so you can't just go, this is not over the counter. This is a prescription.
It's a prescription.
Okay, I'm thinking you mean it's over the counter.
Yeah, no, it's not over the counter.
I'm envisioning you dosing yourself with estrogen.
It's not over the counter.
Yeah. Could it be over the counter though?
Well, they're pretty powerful.
Yeah, like there's a big chance of messing up if you leave it in people's...
I don't see that ever happening.
Okay.
But who knows?
Do you ever see it happening of the bioidentical hormones being introduced in the medical field?
Well, like traditional medicine is always fighting the bioidentical hormone replacement world. Medicine is a business.
Yeah.
And if they could patent natural products and then sell them, they'd make billions of dollars.
Yeah. Have you tried, or not tried, but heard anything on the like natural hormones that people are selling? Like I've seen online, like you don't need a medical prescription because they're all natural. They say they're going to bring back everything, like get rid of your menopausal symptoms.
Well, there are things. There are adaptogens and there are natural products that are over the counter that will address some of the symptoms.
Okay. Are there any that you like?
I'm pretty focused on
yours.
the HRT.
Yeah.
I'm just really busy with that.
Yeah.
There is definitely...
You're not out sampling the ones from Walgreens.
I'm not, but there's definitely validity in them.
Yeah.
There really is.
Well, and I asked because it seems like there's a lot of women who, when they get to that stage, it's almost like they find themselves in a state of desperation.
Absolutely.
That they don't know where to go. They feel like they've asked for help. They've exhausted their options, that nobody is listening. People think they're crazy. They want to put them on an antidepressant.
Absolutely.
And then maybe they get to a place that actually can help them, but insurance doesn't cover it. And they can't afford because it's not cheap. It's not insane, but it's not cheap.
It's not insane.
Yeah. I would also say I didn't go into this thinking my insurance covered it, but one of your girls at the front desk said, I'm going to give you your sheet and you could call.
Oh, you can definitely submit it. Now, it's rare, but I've seen...
They covered my pellets. They said if you were in network, they would have covered 80. I feel like no one's ever in my network though.
Okay.
But they covered 60. So,
well, that's great.
I mean, it's still better. It's better than nothing.
Yeah. And we can run your labs through your insurance.
Yeah.
And a lot of people have health savings accounts and they will use...
Okay.
They will use that to pay for their bioidentical hormone replacement therapy.
But the medical insurance norm is not to pay.
It is not.
Yeah.
It is not.
I hope that changes one day.
I do too.
Or women are going to lose their minds. Okay. A couple questions. If someone, and this actually I was curious too, if someone has a hysterectomy, do they immediately go into menopause?
Well, that depends if it's a full hysterectomy or what we call a partial.
Okay.
So a full hysterectomy is everything. They've taken the uterus and the ovaries, the fallopian tubes. It's all gone.
Okay.
That is medical menopause.
So even if you're 30,
oh yeah,
you're in menopause.
Oh yeah.
Are you having the menopausal symptoms?
Yes.
Wow.
Now, if you leave the ovaries, because the ovaries are what makes the hormones, that's not instant that you're going to go into menopause. But you have cut off 50% of the blood supply that goes to the ovaries, so they're not going to function like they did before.
Okay.
But it still can definitely be enough that women can function just fine for years.
Okay.
Like that.
Okay.
And so what we look at, like from the lab values and the blood work to diagnose being postmenopausal is we're looking at the estrogen level being really low and something called FSH, which stands for follicle stimulating hormone, being really high.
Okay.
Okay. FSH is just a messaging hormone that is sent from our brain to our ovaries, and it tells our ovaries what to do. When we're younger and we're in our childbearing years and everything's working fine, FSH fluctuates depending on what phase of the menstrual cycle you're in, but it really doesn't really go above like 10 or 12.
Okay.
So I'll encounter patients that I can see on their blood work that things are already starting to go wonky, even though that woman could be having very regular periods. Because it's a gradual process. Yeah. But the FSH starts climbing. I think of the FSH as it's a message. And so for years and years, if everything's working right, it just says, hey, ovaries, release a follicle. And then the ovaries respond. Our brains never figure out that our ovaries are not working properly. So when the FSH starts to climb, to me, it's the brain is just raising its voice. Okay. And it raises its voice until it's actually screaming at your ovaries. And that's one way that we can diagnose where this patient is in the menopause journey.
Okay, gotcha. Does menopause affect your thyroid? I know you said you test for thyroid, but does it affect it typically?
Well, I do test for thyroid optimization. It's probably one of the more controversial things that we do.
Why?
And the reason I say that is because inevitably you're going to get a patient who goes to their primary care physician. They don't think of thyroid optimization. They are just looking at that reference range. And if you're within that reference range, they're going to tell that patient, your thyroid's fine.
Right.
It may not be functioning what I call optimally. So what I would do, and anybody who's trained like me would do, is take into consideration what that patient is telling you. You know, they're tired. Their hair's brittle. It's, you know, everything is turned down with a thyroid that's not functioning optimally.
And does HRT treat thyroid?
Does HRT? I mean, it can.
Okay.
It can. I think of thyroid as at the top of the mountain. Okay. And yeah, it can, but that would be actually treating the thyroid.
Okay.
Okay.
Gotcha. So it's not that menopause itself is causing the thyroid.
It's not.
Okay. I saw that video I just showed you. She said my ears are itchy.
I saw that too.
Did you not heard of that?
That is interesting.
Yeah. But she made it sound like it was a common thing. And I was like, I'm like scratching my ears. I'm like, am I going to get itchy ears?
I would think that would be related to dryness.
Oh, okay.
Yeah.
That could have been. All her other ones, I was like, yeah, okay, I can understand that. I can understand. And then she said, my ears are so itchy. And I thought, gosh, this is like one I have not heard of.
Yes.
Okay.
Yeah.
Maybe just dry skin. Okay.
Dry skin, dry eyes.
Okay.
You know, the vaginal dryness.
Okay.
You know, as we age, women don't have to wash their hair as much. It's just everything's drying up.
Yeah. That's why you need the estrogen, the juicy.
You need the juicy hormone.
If someone said, okay, if I don't do any HRT, how long will the menopause symptoms last? Like mainly the hot flashes?
They can last, you know, the literature will tell you 7 years. I mean, they can.
Yeah.
7 to 10 years. You can be dealing with that. But more importantly to me is what's happening to that woman with her brain, her lining of her arteries, her eyes, her heart, her bones.
If I'm asking this selfishly, am on HRT before I go into menopause, should I never get a hot flash? Or no, I should?
Well,
maybe.
You might.
Stay tuned.
You might. I didn't have a ton of drama when I went through menopause because I was already treating.
You were? Okay.
I had testosterone on board and I had a healthy dose of progesterone. I probably quit having a period around 53. I didn't really start taking estrogen until I was around 55 because I was watching my estrogen level and my FSH.
Okay.
So estrogen is the last hormone that I add to a woman's regimen.
Yeah, because I'm not on estrogen.
Right.
Yeah.
And, you know, too much estrogen doesn't feel good. It's the 5 Bs.
What's that?
It's bloated.
Oh.
Bitchy.
Oh.
Boobs hurt, bleeding, breakouts. And so that's why it is the very last thing.
So you need to make sure you don't get too much of that.
Don't want too much of that.
Okay. There's a lot of things to keep track of. Okay. Endometriosis. Someone asked she said that she's had pain her whole life from endometriosis. Once you go through menopause, does that stop?
It can, because if you go through menopause, then if you don't treat your hormone deficiency, then you're living in hormone deficiency. And the hormones do stimulate the tissue growth with endometriosis.
Okay.
So I don't know if I answered that question.
Yeah. I think she's kind of feels like she's been plagued by endometriosis her whole life and is hopeful that when she stops ovulating.
Yes. Well, when she starts not having hormones, it should get better. But then it's like you've got to balance.
Right.
You know, the pros and the cons.
Yeah. What would you say to someone who said, I'm just thinking of responses, to the question I just said of if I stay on HRT going into menopause, will I just breeze through it?
I think you will.
Yeah.
I have a lot of patients that do that.
So what would you say to someone who said, well, you need to let your body naturally do what it's supposed to do?
And I get that question a lot.
I feel like I knew you would, because I will get it.
Yeah. Aren't you messing with nature?
Yeah.
Isn't this a normal process?
Right.
And my first response to that is, hey, we started messing around with nature when we discovered penicillin.
True.
Okay. Yeah. It is a natural process. Mm-hmm. Here's how I look at it. Okay. I don't know if it's okay to say this.
You can say whatever you want. Well, we'll edit it out if we
okay.
need to. I'll say that with a grain of salt.
Okay. I think that there is a perfect design to life. Mm-hmm. I truly do. And as human females, we're really put here from an evolutionary standpoint to procreate, right? By the time that we naturally go through menopause, we would have had time, hopefully, if you're in a jungle somewhere and I'm in a desert somewhere, to teach our tribe how to collect food, build shelter, protect themselves. But we can't all live on this earth forever.
Right.
And so, in my view, our maker, it's brilliant. He just took away our hormones.
Right.
And so
that was the one little thing.
Yeah. And so when you take away the hormones, you're taking away all those protective innate abilities to protect women against all those diseases in old age. Does that make sense?
Yeah. Yeah.
That shows that just shows my religious values and what I think. But it makes sense to me.
Yeah. I love it because I do think it's like, too, there's a lot of diseases that you could not treat and just let take nature's course.
Yes.
But why would you? And you're right when you say about like living a third of our lives past menopause, because there was a time not that long ago where you went through menopause and then you just died. Like, you didn't have that much time left. It was kind of like your purpose on here was done, right?
Right.
You were done having kids.
Right. Suzanne Summers has a whole series of books on bioidentical hormone replacement therapy.
Oh, she does?
Oh, yes.
Oh, wow.
And I think she does a fantastic job of explaining this to non-medical people. But she describes going through menopause as like a woman is a flower and she's bloomed. And then her petals are just falling off. And that really is kind of an accurate...
Yeah.
It's sad,
but
it is accurate.
Well, I love that. Well, you're just out here like saving one woman at a time.
Well, I love what I do.
If someone is listening to this and is like, oh my gosh, that's me. This is what I'm feeling. But I don't live in Nashville, and none of my friends I've never even heard any of my friends talk about this. Like, this is the first time I'm hearing about this. Where do they start to look for someone to help them?
I would Google BHRT near me.
BHRT near me.
Yeah, or bioidentical hormone replacement therapy.
Okay.
There is a resource. It's called simplehormones.com.
Okay. And
that is a colleague of mine who has tried to create a I don't know how you'd say it, like a co-op. So if someone emails him, because he's got connections all over, he will send them providers that are close to them.
Okay, we'll put that up then for sure.
Yes.
Because I think there are a lot of women who, it's not only just that they don't know where to go, if they don't know anyone else. Like when I came to you, it's because a friend of mine had already been to you, right? So I didn't just find some random person and go. So I think that's the other thing is they might be able to find someone on Google, but to have a resource that is a reputable resource that then can say, this is who I would recommend.
Oh, absolutely.
In your area. Okay.
And so that is simplehormones.com.
Okay.
Steve Goldring.
Okay.
Simplehormones.com/ Lisa Grissim.
Okay.
Is a landing page.
Okay.
There's a picture of me there.
Okay.
But then it's Steve who has put together several There may be 12, 14-minute little videos
Okay.
that are very educational.
Okay. We'll
Discussing
put that up
all
for
of
sure.
this. Yeah.
Okay. Because I think that's the thing. Like, I'm sure people will listen to this, like kind of like a one through, which is what I would do, and then go back and rewind and write stuff down, thinking that what pertains to them or questions. So,
And there's more resources. WorldLinkMedical.com has a provider list.
Okay.
I'm sure I'm on that list. With pellet therapy, BioT is a great resource. They have a provider list.
Okay.
Pharmaceo has one.
Okay.
Yeah, there's a lot of avenues out there.
Awesome.
And I would encourage anyone to follow their intuition. I really would. If you are in a place and you don't have a good feeling about the provider, I mean, it's sad, but it's a consumer business.
Yeah. And I think a lot of us are taught too, because our doctor is the expert, that if you sit in their office and they tell you you're fine,
then you think you're fine.
then you just kind of walk out of there thinking, who am I to argue?
Right.
They're the expert. And then you leave feeling defeated. You probably leave feeling even worse about yourself.
Right.
Because you think, this is just me in my head.
And I'm going crazy.
I'm going crazy. They did my blood work and there's nothing wrong with me.
Absolutely.
So.
Have you done any sessions with a functional medicine?
No.
I think your listeners would really gravitate to that.
Okay.
So BHRT is actually a part of functional medicine. Functional medicine is different than traditional allopathic medicine. That's what we all think of when we think of going to the doctor.
Yeah.
It's traditional allopathic medicine, where we're really taught to treat disease, symptoms. We're really not taught to get to the root cause. And so functional medicine is all about, why does this person have that condition?
Right.
Let's not just throw drugs at the symptoms. Let's go to the root cause.
Okay.
And the Institute of Functional Medicine is a great place to start there.
Okay.
I think your listeners would really,
Well, you've given us a lot of information in the best way possible. And I feel like we've answered, I know, all the questions I would have had when I came in that day. And I hope this just gives women kind of a starting place to get some clarity, to not feel alone, to not feel like they're going crazy. I think I know for me, I thought I was the only one. None of my friends had spoken to me about doing anything like this.
Nobody's talking.
Nobody was talking about it. I don't know why.
And I will encourage people, if they're on the fence, do a trial run.
Yeah.
See if you feel better.
Right. And if you don't, then stop. The pellet dissolves. You throw the cream in the garbage. Yeah.
Right. Yeah. Absolutely.
Because what do you have to lose?
Yeah. And I mean, I don't know, maybe that's a whole nother discussion, but delivery methods are just really personal.
Okay.
And you're not stuck into one delivery method or another.
Yeah, you did say that to me. You said, try the pellet, and if you don't like it, then you can switch to something else.
Right. Yeah. And so, it's worth a try.
Yeah. Well, I love it. Well, I so appreciate your time, and I thank you for being here. And after this, I'm sure we'll get lots of feedback and probably some more questions. So maybe we'll have you back one day if you'd be willing.
Thank you. It's been lovely.
Thanks, Lisa.
Thank you.